The differential diagnosis of extracardiac obstructive shock is diverse, but the common pathway is that they impede either ventricular filling or emptying. Massive pulmonary embolism obstructs the pulmonary arteries with clot, impairing right ventricular outflow. This is probably the most common cause of obstructive shock, and though the history may not help much, a personal or family history of hypercoagulable disorder, recent vascular injury, or recent immobility may precede a massive PE. Tension thoracic physiology, from either air or fluid in the chest, impedes filling, mainly of the right heart. A history of chronic lung disease may predispose to pneumothorax, and trauma may cause either a tension pneumothorax or hemothorax. Rarely, patients with chronic pleural disease will accumulate enough pleural fluid over time to create tension physiology. In tamponade, fluid accumulates in the pericardium, compressing the thin-walled atria and right ventricle. This may be due to trauma or due to progressive conditions that cause pericardial effusions, including autoimmune disease, infectious pericarditis, or malignancy. Valvular disease is an uncommon cause of obstructive shock, but progressive aortic or mitral stenosis can do the trick, as can acute thrombosis of a prosthetic valve. The exam in obstructive shock depends on the history and may not be revealing at all. The exam in obstructive shock depends on the history and may not be revealing at all. For right-sided processes, the neck veins might be distended. Heart murmur may point the way to valvular disease. Heart sounds may be muffled in the setting of either pneumothorax or tamponade. Pneumothorax or hemo/hydrothorax cause diminished breath sounds on the affected side. The affected hemithorax is resonant to percussion in pneumothorax and dull to percussion in hemo or hydrothorax. Patients with pulmonary embolism may have unilateral leg swelling reflecting deep vein thrombosis and may have an accentuated second heart sound reflecting pulmonary hypertension. Evaluation for pulmonary embolism is indicated by the history and physical discussed previously. Evaluation for pulmonary embolism is indicated by the history and physical discussed previously. Imaging studies should include a CT angiogram of the pulmonary arteries and an ultrasound of the legs for DVT. Labs should include a D-dimer and coagulation studies in addition to the standards. Serum BNP and troponin can help risk stratify patients with PE. An echocardiogram showing right ventricular dysfunction can be helpful as well. Let's examine what happens in PE. Ordinarily, the right ventricle ejects into the pulmonary arteries. When a clot obstructs flow in the pulmonary arteries, right ventricular outflow and thus overall cardiac output is diminished. This can result in right ventricular dilation and failure. The interventricular septum can actually bow into the left ventricle due to right ventricular overpressure. This can have deleterious effects on left ventricular function as well. Here is a CT angiogram of the chest. We're looking at a cross-section through the pulmonary arteries at about the level indicated by the dashed line on the diagram at left. We look from the feet towards the head, so the patient's right side is on our left. For orientation purposes, here are the superior vena cava, aorta, and pulmonary artery. This dark mess inside the pulmonary artery is clot. We'll discuss tension physiology next, using pneumothorax as our example. The predisposing history and physical is discussed above. This is the one exception about the chest x-ray. If you think a patient has a tension pneumothorax, don't capture it on film. The delay in obtaining an x-ray may be the difference between life and death. If point-of-care ultrasound technology and expertise are immediately at hand, this can help exclude a pneumothorax. But if you are unable to exclude a tension pneumothorax, you should immediately decompress it with a large bore needle or IV catheter at the second intercostal space at the midclavicular line. Labs aren't often helpful here. In tension pneumothorax, inflow from the vena cava is restricted by compression, reducing effective preload and diminishing cardiac output. This is what it looks like on imaging. Notice how the cardiac silhouette is shifted away from the affected side. In the scout film at the left, you can see that the trachea is deviated from midline. This can be seen on physical exam and help aid in the diagnosis. The last specific extracardiac obstructive diagnosis we'll discuss is tamponade. This is caused by compression of the heart by fluid in the pericardium. The key history and physical findings were discussed. Often a pulsus paradoxus is seen, where the respiratory variation of systolic blood pressure is such that you can hear the pulse come and go when taking a manual blood pressure. This is largely lost in modern medicine with widespread use of automated blood pressure measurement. Point-of-care ultrasound or formal echocardiography is almost always used to confirm the diagnosis, and labs generally aren't helpful initially. Tamponade compresses the right atrium and ventricle, impeding venous inflow. This is what it looks like on ultrasound. The chest wall is at the top. The heart is beating and swimming in a sea of pericardial fluid. You can see how both the left and right atria are indented by the pressure in the pericardium. The right ventricle, which is on your left, compresses near the apex.